Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria Mulherker. I am now a PGY5 resident at the University of Pittsburgh, and today we will be discussing vulvar cancer and wrapping up our series on gynecologic cancers. Vulvar cancer is actually a very rare cancer, accounting for just around 5% of all gynecologic cancers and less than 1% of all cancers. The risk of vulvar cancer increases with age, with the peak incidence in the 7th decade. And most commonly, the histology is squamous cell carcinoma, which makes sense because of where it's located. Now, vulvar cancer can have some different risk factors. So for HPV-dependent cancers, that can include vulvar intraepithelial neoplasia, or VIN. And for HPV-independent processes, it can include things like vulvar dystrophies, such as lichen sclerosus, which has around a 5% risk of malignant transformation. So these are some pre-malignant lesions that patients will often have before they go on to develop vulvar cancer. I think the literature for vulvar cancer isn't quite as overwhelming as it was for cervical and endometrial cancer. And so my hope is in this singular talk to go over not just the presentation, workup, staging, and management paradigm, but also address a lot of the evidence in vulvar cancer and kind of try and consolidate this all into just one talk as opposed to splitting it into two. So let's dive into some background. Vulvar cancer will often present with an erythematous or ulcerated lesion that may or may not be associated with bleeding or pruritus. If groin nodes are present, they may be palpable and sometimes they can actually ulcerate through the skin. It is possible for vulvar cancer to present with synchronous cervical cancer, and if it metastasizes, the lung is the most common site for distant spread. In terms of workup, you should always think about a history and physical with a complete pelvic and rectal exam, getting labs such as CBC, LFTs, pregnancy test as indicated. You always want to get a biopsy with testing for HPV. And then in terms of imaging, an MRI of the pelvis with and without contrast is very helpful to assess local spread. And then consider a PET CT scan for clinically advanced disease, especially to help visualize involved nodes. In terms of anatomy, most commonly vulvar cancers will be located on the labia majora or minora, and 10 to 15% of the times they may involve the clitoris, and they can also involve the mons pubis. In terms of lymphatic drainage, the regional lymph nodes for vulvar cancer are considered the inguinal nodes, and the risk of nodal involvement is proportional to the thickness of the tumor. Keep in mind that pelvic nodes, when it comes to vulvar cancer staging, are actually considered metastatic. So inguinal nodes are the regional nodes, and if there are pelvic lymph nodes involved, then that's actually considered metastatic. In terms of pathology, as we said, most commonly vulvar cancers are squamous cell carcinomas. So over 90% of cancers are typically squamous cell. When we look at the pathology report, there are certain patterns of invasion that are recognized as more risky or more aggressive. For example, spray pattern, which is often very infiltrative tumor, or diffuse pattern, which is typically associated with larger tumors that are deeply invasive. So keep in mind that spray and diffuse patterns are just more risky. Less common histologies include things like melanoma or an adenocarcinoma from Bartholin's gland, which is actually quite rare. So in this pink box, I just have some things that you should always keep in mind on the pathology report. And I think these are pretty standard for most cancers. So always the tumor size, the location, the number of foci and the depth of invasion, the histology, the grade, the margins, presence of LVSI, the method for lymph node sampling and number of lymph nodes, as well as their measurement, and any notes for extracapsular extension as well if there was a pelvic lymphadenectomy. There was a study, GOG 36, which is a fairly old study, but it showed that the risk of nodal involvement increases with the tumor thickness, as you might expect. And nodal involvement is the most important prognostic factor. So you can see that as tumor thickness goes from 1 to 5 millimeters, the risk of nodal involvement increases drastically, 3%, 9%, 20%, 30%, and 33% with 5 millimeter tumor thickness. And when tumor thickness was greater than 5 millimeters, there was a 50% risk of nodal involvement. So dramatic increase with tumor thickness. And now keep in mind that in FIGO staging, they don't use tumor thickness, but stromal invasion, which is similar to, but not identical to how you measure tumor thickness in GOG 36. But stromal invasion is also considered a risk factor. And for tumors that are less than or equal to 1 millimeter stromal invasion, it's okay to omit sentinel lymph node biopsy due to very low risk of nodal involvement, less than 8%. But all other tumors, anything greater than 1 millimeter of stromal invasion, requires a sentinel lymph node biopsy. So here we have the 2021 FIGO staging for vulvar cancer, which we can quickly review. So stage 1 disease is anything that's confined to the vulva, and 1A and 1B are separated based on the tumor size and stromal invasion. So anything less than or equal to 2 millimeters for tumor size and anything less than or equal to 1 millimeter for stromal invasion is considered stage 1A. And then 1B is anything that's confined to the vulva that's not 1A. So tumor size greater than 2 millimeters or stromal invasion greater than 1 millimeter. The stage 2 disease then is anything that extends to the lower 1/3 of the urethra, the vagina, and the anus. So I think it's kind of easy to remember. There's really 3 tubes in the perineum that kind of exit in the perineum, and those are the urethra, the vagina, and the anus. So extension to the lower 1/3 of any of those is stage 2, and you cannot have any lymph nodes involved. If it goes to the upper 2/3 of any of those things, or there are positive lymph nodes, that makes it stage 3 disease. So stage 3A is any disease that's extending to the upper 2/3 of the urethra, vagina, or the anus, or if there are any regional lymph nodes that are less than or equal to 5 millimeters in size. And remember, for vulvar cancer, inguinal and femoral nodes are considered the regional nodes, and anything in the pelvis, like any of the iliac nodes, those would be considered actually metastatic disease. So stage 3A is upper 2/3 of any of those tubular organs or lymph node less than or equal to 5 millimeters, and that's a regional lymph node. If it's greater than 5 millimeters for the lymph node, then that makes it stage 3B disease. And if there's any extracapsular extension of the lymph node, then that makes it 3C disease. And then stage 4 disease is divided into A and B. So stage 4A is any disease that's fixed to the bone, or if there is a fixed or ulcerated lymph node. And stage 4B is anything that's distant metastasis. And that, remember, includes pelvic nodes. Now that we have some background and staging under our belts, let's get into the management of vulvar cancer. So stage 1A disease, remember that is disease that is less than or equal to 2 millimeters in size with less than or equal to 1 millimeter stromal invasion. 1A disease can be managed with wide local excision with consideration for re-excision if there's a positive margin. And as long as the invasion is less than or equal to 1 millimeters, the margins are negative, and there's no additional risk factors, there's often not a necessity for any adjuvant therapy. Anything more advanced than that, though, really needs surgery and possibly radiation. So stage 1B to 2 disease, remember stage 2 disease is anything extending to the lower 1/3 of the urethra, the vagina, or the anus. A radical local excision or a modified radical vulvectomy can be possible per the surgeon, and an inguinal sentinel lymph node biopsy is negative as well. If there is a well lateralized primary that's over 2 centimeters from the midline, then the sentinel lymph node biopsy can be unilateral, but in other cases it does need to be bilateral sentinel lymph node biopsy. After radical local resection or modified radical vulvectomy in these cases, there are various indications for radiation to the vulva versus radiation to the inguinal and pelvic lymph nodes. And very shortly, we will kind of get into the studies and talk about the evidence for this. But in terms of radiation to the vulva, you can consider if there are margins that are less than or equal to 8 millimeters, if there is LVSI, if there is greater than 5 millimeter depth of invasion, if there is larger tumor size, or that diffuse or spray histology. And in terms of indications for radiation to the inguinal and pelvic nodes, that should be considered if there are 2 or more positive nodes, if there is extracapsular extension, and it can also be considered for situations where there is even 1 positive nodes with less than 12 nodes dissected without sentinel lymph node biopsy. And in the adjuvant setting, there really aren't clear indications for concurrent chemotherapy. For stage 3 to 4A disease, oftentimes upfront radical vulvectomy is not possible, especially if the disease is extending to the top part of the urethra or the anus or something like that. And so if the disease is not resectable up front, then oftentimes neoadjuvant chemoradiation is the answer. And then after neoadjuvant chemoradiation, we can consider biopsy as well as organ-sparing surgery if possible, if there's not a complete response. So that was probably a lot to process in terms of how we manage vulvar cancer, but I think it'll make more sense as we start to dig into the evidence, and that'll kind of bring to light kind of why we do what we do. So let us start by talking about some studies that looked at patients with early stage vulvar cancer and investigated indications for post-operative radiation. And what we find is that patients that have either close margins, defined as less than 8 millimeters, or positive margins are those patients that benefit from post-operative radiation. And as we said a little bit earlier, it's not just the margin status, but per NCCN guidelines, we also consider other tumor-specific risk factors to consider post-operative radiation. So those things include things like LVSI, the size of the tumor, depth of invasion, and high-risk histologies such as that diffuse or spray histology that we talked about. The first study I will mention is a retrospective study from UCLA by Heaps et al. That looked specifically at risk factors for recurrence. They retrospectively reviewed 135 patients with stage 1 to 4 vulvar squamous cell carcinoma after undergoing surgery, and the majority of patients underwent radical or modified radical vulvectomy with lymph node dissection. And in their analysis, they found several risk factors for local recurrence. So those included stage of disease, margins less than 8 millimeters, depth of invasion greater than 9 millimeters, tumor thickness greater than 2.5 millimeters, LVSI greater than 25% keratinization, and greater than 10 mitoses per high-powered field. And so I think all of these factors are very important to keep in mind because they were all statistically significant risk factors for local recurrence. Another study that just specifically looked at the benefit of radiation for close or positive margins was another retrospective study by Fall et al. And they studied 62 patients retrospectively with vulvar cancer who had undergone resection, who had either close margins defined as less than 8 millimeters or positive margins. And 50% of these patients had received adjuvant radiation, so radiation to the vulva, bilateral inguinal nodes, as well as the low pelvis. And the dose was prescribed to a 3 centimeter depth for inguinal nodes. And the remaining 50% were just observed. And, keeping in mind the caveats of any retrospective study, the local recurrence was found to be 58% with observation versus 16% with adjuvant radiation. And the local recurrence, when they separately looked at patients with close versus positive margins, both were statistically significant for improvement with adjuvant radiation. So in patients with close margins, recurrence went from 30% down to 5%. And for patients with positive margins, the recurrence risk went from 70% down to 33% with the addition of adjuvant radiation. And so this is now retrospective data that adjuvant radiotherapy improves local control for high-risk patients, which is defined as patients with close or positive margins, so anything less than 8 millimeters. There was a more recent Dutch retrospective study that was published, and this included 287 patients with early-stage vulvar cancer status post-surgery. And they kind of revisited this question of margin status. The patients that they included had close margins, less than 8 millimeters, and these patients were all closely followed. And adjuvant radiotherapy was really only indicated if patients had greater than or equal to 2 nodes or extracapsular extension. And when they followed these patients, what they found is that 43% of the patients had a local recurrence within 10 years, and the pathologic tumor-free margin distance had no effect on local recurrence. They had small groups, and so they used different cutoff values at 3 millimeter close margin, 5 millimeter close margin, and 8 millimeter close margin. But they really did not find any significance. They also looked at other things, including growth pattern, LVSI, grade, tumor size, depth of invasion. But again, these were not significant. The only actual factors that they did find were significant for local recurrence were differentiated vulvar intraepithelial neoplasia, plus or minus lichen sclerosis. And so based on this Dutch data, there is an argument for, not considering radiation just in the case of a close margin. And this data suggests that observation may be acceptable for margins that are greater than or equal to 3 millimeters in early stage vulvar cancer after surgery. I think it's important to keep in mind that we might be unlikely to just treat for a close margin. Usually there are other higher risk factors as well. And so it's really important to think about all of those factors that we mentioned previously. And if multiple ones are present, then that might be reason to consider adjuvant radiation. I also think that while in real life, we might consider just observing in the presence of a close margin that's greater than or equal to 3 millimeters, especially if patients are going to be compliant with follow-up. I think that for the purposes of boards, for now at least, it is important to remember sort of that 8 millimeter cutoff. Okay, so hopefully that made a little bit of sense, and everything we just talked about was really indications for adjuvant radiation to the vulva based on risk factors for the primary tumor. Let's move on now and talk about indications for postoperative radiation to the groin and pelvis. So what are reasons not just to treat the primary, but to actually treat the whole groin and the pelvis? And it turns out that the indications are greater than or equal to 2 positive nodes, fixed or ulcerated nodes, and extracapsular extension. So let's talk about why. The most important randomized trial to remember for indications for pelvic radiation in the case of positive nodes is GOG 37. So this is a fairly old trial, ran in the 70s and 80s, and they took patients with stage 1 to 4 vulvar cancer who were undergoing radical vulvectomy and bilateral inguinofemoral lymph node dissection who had positive nodes during surgery. If they were found to have positive lymph nodes, they were intraoperatively randomized to either undergo further surgery with ipsilateral pelvic node resection, so that means removing ipsilateral obturator, internal and external iliac, and common iliac nodes, or no further surgery and just bilateral pelvic and groin radiation to 45 to 50 gray. And they just radiated the pelvis and the bilateral groin, but they did not do central vulvar radiotherapy. What they found is that radiation improved outcomes in patients that had 2 or more positive lymph nodes in the groin, extracapsular extension, or fixed or ulcerated lymph nodes. The 2-year groin recurrence was 24% in the surgery group versus 5% in the group that received radiation, and that was statistically significant. The overall survival went from 68% with the surgical approach to 54% with radiation. And again, that was statistically significant. And in subgroup analysis, the effect was really predominant in patients that had 2 or more positive nodes or extracapsular extension. The 6-year overall survival also went from 51% to 41%, which was not significant, but they did find significant improvement, again, in 2 or more positive nodes, fixed or ulcerated nodes, or extracapsular extension. The other factor that emerged as important was having 20% or more positive lymph nodes in the groin. Having more than 20% groin lymph node positivity was associated with significant risk of contralateral lymph node metastasis, relapse, and cancer-related death. And with the addition of radiation, it turned out that there was not a significant difference in skin toxicity or lymphedema. And so the GOG37 actually tells us that for patients that had 2 or more positive nodes, extracapsular extension, or fixed or ulcerated nodes, as well as 20% or more lymph node positivity, there is a benefit to adjuvant pelvic and inguinal radiation. So GOG37 was a randomized study, which remember is considered level 1 evidence. There's also a SEER analysis for sort of the same question, but keep in mind that SEER data is limited, it is retrospective, and so it definitely comes with its caveats. But this SEER study took 208 patients that had vulvar squamous cell carcinoma with a single positive lymph node, and 92% of the patients in this study had undergone a radical vulvectomy and either unilateral or bilateral inguinal lymph node dissection. And then around half of the patients underwent adjuvant radiation. And what they found is that if the patients had a single positive lymph node, there was improved 5-year disease-specific survival with adjuvant radiation. However, this was especially true if less than or equal to 12 nodes were removed. So in the entire cohort, the 5-year disease-specific survival went from 77% with radiation down to 61% without radiation, and that was significant. But for patients that had less than or equal to 12 nodes removed, it was 77% down to 55%, statistically significant. And if patients had over 12 nodes dissected, then the significance was lost. And so the SEER data suggests that there might be a benefit to adjuvant radiation if we have a single positive nodes and less than or equal to 12 nodes are removed. So kind of combining the GOG and the SEER studies, it's really 2 or more positive nodes or a single positive nodes with less than or equal to 12 nodes dissected, or if there is extracapsular extension or a fixed or ulcerated lymph node, these are really indications for adjuvant radiation. And keep in mind that even though it's just the inguinal and femoral lymph nodes that are considered the regional nodes for vulvar cancer, when these patients received adjuvant radiation, they also received radiation to the low pelvis. And so that is the standard to treat not just the inguinals, but also the low pelvis. In terms of the role for chemotherapy, we really don't have great data for adding chemotherapy in the adjuvant setting. There was an NCDB analysis of close to 2,000 patients who had vulvar squamous cell carcinoma, status post-surgery with pathologic node-positive disease. And this study included patients that were treated with adjuvant radiotherapy and kind of analyzed the use of adjuvant chemotherapy. And what they found is that the use of adjuvant chemotherapy kind of increased over time, and use of chemo was associated with greater number of positive lymph nodes, stage 4A disease, and presence of positive margins. And the use of adjuvant chemo in pathologic node-positive patients was significantly associated with a reduced mortality risk. So the median overall survival went from 30 months without chemo up to 44 months with chemo, which was statistically significant. And there was a 38% reduction in the risk of death. So again, we don't have good prospective data on the role of chemotherapy in the adjuvant setting, But based on retrospective data from an NCDB analysis, it turns out that adjuvant chemotherapy may benefit patients that have pathologic lymph node positivity. So up until now, all of the trials that we have discussed, the historical trials, really utilized inguinofemoral lymph node dissection to assess the lymph nodes. In the modern era, we are utilizing sentinel lymph node biopsy, and based on the findings of sentinel lymph node biopsy, we're determining if patients really need to go on to complete a lymph node dissection, or if we can substitute with inguinal radiation, or if we can even omit. And remember, the patients that require sentinel lymph node biopsy are any patients with at least FIGO stage 1B disease. So if they have greater than 1 millimeter invasion of their tumor, then they need at least a sentinel lymph node biopsy. And then based on the findings, we offer some risk-based treatment. So let's talk about the trials from which we get these treatment paradigms and how we kind of risk stratify after sentinel lymph node biopsy. GOG 88 is a historical trial that tried to see if we can substitute groin dissection with inguinal radiotherapy and kind of omit groin dissection in patients with vulvar cancer. So this trial ran in the late 80s, and they had 58 patients with T1 to T3 clinical node negative vulvar cancer who were amenable to radical vulvectomy. And they were randomized to either radical vulvectomy plus bilateral inguinofemoral groin dissection or radical vulvectomy plus inguinal radiotherapy. And inguinal radiotherapy consisted of 50 gray and 25 fractions prescribed to a 3 centimeter depth. And in their radiation treatment fields, they kind of blocked off that central vulvar region and just treated the groins. Unfortunately, this trial closed early because they had worse outcomes in the radiotherapy arm. The progression-free survival was significantly worse, 90% with lymph node dissection versus 65% with radiation. And the overall survival was also significantly worse, 85% with dissection versus 60% with radiation. And the rate of groin recurrence was 0% with surgery, but 18% with radiation. It turned out that this trial is actually criticized for underdosing the groin because they only prescribed to a 3 centimeter depth, and the mean depth for patients, where their nodes were located, was actually 6 centimeters. So in GOG 88, major criticism of this trial is that the radiation technique that they used was actually not adequately even treating the groins. We were missing that inguinal lymph node region. And in all of the 5 patients who failed, the tumor dose was less than 47 gray. So it's probable that in GOG 88, these patients just were not adequately treated. Also keep in mind that of the patients in the dissection arm, 20% turned out to be node positive. Remember, these were clinically node negative patients, and 20% turned out to be positive, and they were treated with adjuvant radiation. So the conclusion from GOG 88 is that groin dissection is superior to inguinal radiotherapy alone, with this major caveat that GOG 88, the radiation technique, was probably inadequate and it did not sufficiently cover the inguinal regions. They were prescribing to a 3 centimeter depth, when in reality, the majority of patients, the mean depth where their inguinal nodes were located was at 6 centimeters. So far, based on GOG 88, even though the trial, the radiation technique was probably inadequate, the data that we have tells us that inguinal femoral lymph node dissection is superior in terms of overall survival and progression-free survival compared to lymph node radiation. So the standard of care at this point is still to do inguinofemoral lymph node dissection. The Groins V trial introduced this idea of sentinel lymph node biopsy and entertained the idea of observation if patients had negative sentinel lymph node biopsy. So this trial ran in the early 2000s, and they took vulvar cancer patients with T1 to T2 disease, less than 4 centimeter tumor, greater than 1 millimeter depth of invasion, and patients that were clinically node negative. They performed sentinel lymph node biopsy using blue dye and radioactive tracer in 403 patients, and 259 of those patients had negative sentinel lymph node biopsies. So all of the patients had a radical excision of the primary plus a sentinel lymph node biopsy. And then if that sentinel lymph node biopsy was negative, they went on to receive no further treatment. They were just observed. And so of these 259 patients who were sentinel lymph node negative, what they found is that there were very low rates of groin recurrence when inguinal dissection was omitted in the setting of a negative sentinel lymph node biopsy. The 5-year actuarial groin recurrence was 2.3% in patients that were sentinel lymph node negative, and the median time to groin recurrence in those that did recur was 12 months. In the case of recurrence, they received salvage therapy with bilateral inguinofemoral lymphadenectomy, as well as adjuvant radiation plus or minus chemotherapy. And keep in mind that if the patients had multifocal disease, then the recurrence risk was 3%. And actually, on a later protocol amendment, patients with multifocal disease were omitted from this study. In terms of the 5-year local recurrence, that was 12%. And so Groin's V tells us that if patients have a negative sentinel lymph node biopsy, there is still kind of low groin failure rates when lymph node dissection is omitted. And so this might be a safe option and kind of a good way of determining who actually needs to proceed with a full inguinofemoral lymph node dissection. The Groin's V1 publication was kind of the other half of that study, right? So if patients had negative sentinel lymph node biopsy, then any further dissection was omitted and they were just observed. If patients had positive sentinel lymph node biopsy, they then did go on to receive inguinofemoral lymphadenectomy with post-op radiation to 50 gray if they had 2 or more lymph nodes or extracapsular extension. And it turned out that 10% of the patients that were sentinel lymph node biopsy positive after the lymph node dissection went on to receive radiation. And this is kind of the other half of that study, and it tells us that we still need to pursue lymph node dissection if patients do have positive sentinel lymph nodes. But the patients that have early stage vulvar cancer and negative sentinel lymph nodes have low groin recurrence, good survival, and less toxicity. And if we go ahead and look at that second table here on this slide, we compare some of the short-term versus long-term toxicities, and everything is significantly improved in the patients that had no lymph node dissection. So wound breakdown, cellulitis, lymphedema, recurrent erysipelas, the rates of all of these short and long-term complications are significantly lower with no lymph node dissection. And so by using sentinel lymph node biopsy to kind of find out which patients do not have any sentinel nodes positive, we are sparing a significant subset of patients from all of these short and long-term complications. There was a subset analysis that was later published, which said that the size of the sentinel lymph node metastasis showed significantly worse prognosis if sentinel lymph nodes were greater than 2 millimeters. But there was no safe size cutoff that was established for the omission of lymph node dissection. So based on the Groin's V and Groin's V1 data, any patients that had positive sentinel lymph nodes needed to really go on to receive that inguinofemoral lymphadenectomy. And if you take a look at the table on the left-hand side, you can see kind of as expected, the rates of local recurrence, disease-specific survival, and overall survival are significantly worse in the patients that had positive sentinel lymph nodes. And that's expected, right? Because they probably just have more advanced disease. So the bottom line from Groin's V1 is that we can safely omit lymph node dissection in early stage patients that have negative sentinel lymph nodes. But if patients have positive sentinel lymph nodes, then the standard of care really is to perform inguinofemoral lymphadenectomy. GOG 173 is the other study that looked at sentinel lymph node biopsy guided inguinal lymph node dissection. And they took patients with vulvar squamous cell carcinoma with tumor size measuring 2 to 6 centimeters, again with greater than 1 millimeter depth of invasion, and patients that were clinically node negative. And they had them undergo sentinel lymph node biopsy using blue dye and radiocolloid, and all of the patients then were followed with inguinal dissection. So for 92% of the patients, they were able to identify sentinel lymph nodes, and the incidence of nodal metastasis was 32%. The false negative rate of the sentinel lymph node biopsy was 8.3%, and the overall sensitivity of the procedure was 91.7%. And then the false negative predictive value was 3.7% in all comers, and 2% if the tumor was less than 4 centimeters versus 7.4% if the tumor was 4 to 6 centimeters. So GOG 173 again tells us similar finding that sentinel lymph node biopsy is a reasonable alternative to inguinal lymph node dissection. And women with tumors less than 4 centimeters have less than 3% chance of groin relapse due to a false negative sentinel lymph node biopsy. So, it's a fairly safe procedure. Keep in mind that as the tumor size increases, as we get to 4 to 6 centimeters, then that false negative rate does increase a little bit. But especially in women with tumors that are less than 4 centimeters, that chance of a false negative is less than 3%. Now, Groin's V2, also known as GOG 270, is an even more modern study. It's a phase 2 prospective non-randomized observational study looking at radiation versus lymph node dissection in patients that had positive sentinel lymph nodes. So in this trial, they included 1,500 patients that had early stage vulvar cancer with a diameter of less than 4 centimeters that were clinically node negative, and they were treated with primary surgical excision plus sentinel lymph node biopsy. And all of the patients with sentinel lymph nodes that were positive underwent 3D conformal radiotherapy to 50 gray to the inguinofemoral and distal external iliac nodes. The vulva was only covered if there were close or positive margins, and they allowed ipsilateral nodal radiation alone in patients that had well lateralized tumors. So in this study, 21% of the patients had positive sentinel lymph nodes, and in June of 2010, the study actually had to activate their stopping rule because 10 out of the 91 patients with positive sentinel lymph nodes and adjuvant radiotherapy had isolated groin recurrence. And 9 out of 10 of these patients had lymph nodes that were greater than 2 millimeters or extracapsular extension. And because the stopping rule was activated, the protocol was then modified to allow adjuvant radiation only in the case of sentinel lymph node micrometastases. So tumor in the sentinel nodes that was less than or equal to 2 millimeters. And it turned out that among the patients that had sentinel lymph node micrometastases, the 2-year groin recurrence rate was very low at 1.6%. However, in patients that had sentinel lymph node macrometastases, the rate of groin recurrence was 22% with radiation versus 7% with lymph node dissection, and that was statistically significant. The lymphedema rate, as you can imagine, was much higher with lymph node dissection, 22% versus 10% with radiation, also significant. But the rate of groin recurrence was unacceptably higher in this study for patients that had sentinel lymph node macrometastases. So really based on Groin's V2, the conclusion is that for patients that have micrometastases on sentinel lymph node biopsy, so tumor foci that are less than or equal to 2 millimeters, adjuvant radiation is a safe alternative to lymph node dissection. However, if we have macrometastases, then the groin recurrence is higher compared to with radiation alone compared to if we offer a lymph node dissection. Now, interestingly, in response to Groin's V2, there was a kind of controversial editorial that was published that interestingly actually came from a former trainee at my institution. The point of this editorial was that the contouring guidelines in the original Groin's V2 protocol asked for contouring the inguinal nodes using a 5 millimeter margin around the inguinofemoral vessels. Now, when we contour nodal regions in the pelvis, we typically use a 5 to 7 millimeter margin around the vessels, and that is considered adequate, and we end up covering adequately the pelvic lymph nodes if we do that. In the groins, however, the inguinal compartment is more than just a 5 millimeter margin on the inguinal vessels. If you take a look at this picture, the purple outline shows, the vessels. The blue outline shows a 5 millimeter margin on those inguinofemoral vessels. And the red outline actually shows the extent of the inguinal compartment. And so the title of this article was actually, "Are We Missing the Target Again?" Alluding to GOG 88, where, remember, they prescribed to the 3 centimeter depth, when in reality, a lot of the women had nodes that were located at a 6 centimeter depth. And so GOG 88 kind of missed the target. And once again, in that study, we saw that radiation performed inferiorly to surgery, that complete inguinofemoral lymph node dissection, and perhaps that was because we were missing the target. And in Groin's V2, perhaps we were missing the target again by not adequately contouring the inguinofemoral compartment. So the protocol was modified in 2015 for Groin's V2 to kind of adequately contour the inguinofemoral compartment. But the major criticism is that prior to 2015, the patients that were included in the study, we were probably missing the nodal target with radiation. Now, it's important to realize that when we're contouring the nodal region for our radiotherapy plans, we need to include the entire inguinofemoral compartment. And if we point out the muscles, there's a nice mnemonic that came from one of my mentors. The mnemonic is "Sorry, rest in peace, a-hole." And so it kind of shows us the borders of the inguinofemoral compartment. And so anteriorly, we start at the sartorius muscle, and then go along the rectus femoris, the iliopsoas, which is the lateral border, the pectineus up until the medial edge is the posterior border of the compartment, and then the lateral edge of the adductor longus is our medial border. And so the mnemonic for all of these muscles, and you can kind of see it drawn out in this image, is "Sorry, rest in peace, a-hole." So sartorius, rectus femoris, iliopsoas, pectineus, and adductor longus as we move kind of from anterolateral to the medial border. So based on these studies, we have Groin's V1, which told us that if patients have negative sentinel lymph node biopsy, then it is probably safe to omit inguinofemoral lymph node dissection and just observe. If patients have micrometastases, so less than or equal to 2 millimeter foci of disease on sentinel lymph node biopsy, then we can substitute inguinofemoral lymph node dissection with radiotherapy to 50 gray. And, based on Groin's V2, in the case of macrometastases, so anything greater than 2 millimeters, it's really not safe, and inguinofemoral lymph node dissection is still the standard of care. Groin's V3, also known as NRG-GY24, is an ongoing study that is presently accruing, and it is studying the role of concurrent chemoradiotherapy in patients that have sentinel lymph node positive disease. And the study is including both macro and micro metastases. So they're treating with 48 to 50 gray to the inguinal and external iliac regions, and then a 56 gray boost to involved inguinal sites using a simultaneous integrated boost technique. And they are treating with concurrent chemotherapy, cisplatin 40 milligrams per meter squared weekly. So that'll be certainly interesting to follow. So far we have talked about early stage vulvar cancers that are amenable to upfront resection. And so when they are amenable to upfront resection, the patients should get resection of the primary tumor, as well as sentinel lymph node biopsy, and then tailored treatment, as we have just discussed. There are some patients, though, as we discussed during the staging portion of our talk, who are considered unresectable, potentially because the tumor is stage 3 and it's kind of invading the upper 2/3 of some of those structures, such as the urethra or the anus or the vagina, and the disease is too advanced for a reasonable upfront resection. And so let's spend a few minutes talking about some of the trials that address the standard of care in these patients, which is really preoperative chemoradiotherapy. GOG 101 was a phase 2 prospective study that looked at split-course chemoradiotherapy for patients with stage 3 to 4 vulvar squamous cell carcinoma that was not amenable to vulvectomy. The patients were treated with radiotherapy to 47.6 gray in 28 fractions, followed by surgery after 4 to 8 weeks. The treatment was a three-dimensional technique using APPA fields, and then the patients were treated with 23.3 gray, followed by a 1.5 to 2.5 week break based on skin toxicity, and then 23.6 gray on the back end of that. The vulva only was treated if patients had clinical N0 to 1 disease, so kind of the dotted line in the diagram, that was the field. And then the pelvis and inguinals were added only if patients had CN3 to 4 disease, so the solid line. The concurrent chemo that was utilized was 5-FU plus cisplatin with each split course. And if the patients did not have any response after this upfront radiation, an additional 20 gray were added. And if patients had a positive margin at the time of surgery, additional 10 to 15 gray were added. The trial showed a high resectability rate of around 95% after preoperative chemoradiotherapy. And for the primary tumors, they had a clinical complete response in about 46%, a PCR rate of 35%, with only 3% of the tumors unresectable. And then for node-positive disease, the pathologic complete response rate was 47%, with only 5% unresectable. And so GOG 101, the conclusion is that, pre-op chemoradiotherapy for unresectable locally advanced vulvar cancer is feasible and reduces pelvic exenteration. What we realize now is that split-course radiotherapy really is not ideal because it allows time for tumor repopulation. With vulvar cancer, the skin toxicity can be very severe, and it's very important to monitor that and to manage it for our patients. But we try at all costs not to have interruptions in treatment because we don't want to allow time for the tumor to regrow. GOG 205 was a more modern study looking at concurrent cisplatin plus radiation to 57.6 gray in 32 fractions. And they took patients with unresectable vulvar cancers and treated them with chemoradiation followed by surgery. So the dose, again, was 57.6 gray in 32 fractions, delivered consecutively over 6.4 weeks, so no more breaks in between the treatment. Again, the dose was delivered with APPA fields, so kind of a more rudimentary three-dimensional technique. And 45 gray were given to the nodes, if nodes were treated, followed by a cone down for a sequential boost to the primary and nodal tumor GTVs with a 2-centimeter margin. The radiotherapy was delivered with concurrent weekly cisplatin, 40 milligrams per meter squared, and then surgery was delivered 6 to 8 weeks after. Of note, the protocol did allow for preoperative inguinal lymph node dissection if patients had either clinically node-negative disease or operable lymph nodes, but otherwise they had upfront chemoradiotherapy entirely. The response was actually improved compared to GOG 101. The clinical complete response rate was 64%, and the pathologic complete response rate was 50%. And again, it was probably improved because they were no longer offering that break in between treatment. That break helps with toxicity. It allows the skin to heal. But unfortunately, the treatment break also allows time for the tumor to repopulate. And so it's a difficult balance, but we really do not want to allow that tumor to regrow. And the GOG 205 regimen was well tolerated as well. So around 80% of patients completed the planned radiation, 70% received all 5 planned cycles of chemotherapy, and mostly the grade 3 plus toxicities were hematologic. The majority of patients had grade 1 to 2 radiation dermatitis. So GOG 205 kind of established the standard of neoadjuvant cisplatin plus radiotherapy for patients with inoperable vulvar cancer, and this yielded high response rates. So again, the clinical complete response rate was 64% in GOG 205 versus 46% in GOG 101. The pathologic complete response rate was 50% in GOG 205 versus 35% in GOG 101. So better outcomes there. At my institution, UPMC, we have typically been utilizing dose-escalated IMRT as opposed to the 3-dimensional techniques that were utilized in the GOG trials that we just discussed. And we published a retrospective review of 49 women that were treated with dose-escalated IMRT for locally advanced vulvar cancer. And so the patients received at least 55 gray. So typically uninvolved elective nodal regions received 45 gray and 25 fractions, so usually the pelvis. Uninvolved inguinal nodal regions received 50 to 50.4 gray, and any clinically involved lymph nodes were treated to 55 to 58.8 gray with a 4 to 6 gray sequential boost if the nodes were greater than 2 centimeters. And then the vulvar GTV, so the primary tumor within the vulva, was sequentially boosted to 56 to 60 gray if patients were going to be receiving surgery. And if they were not candidates for surgery at all, then the vulvar GTV was treated to 66 to 68 gray. So IMRT was definitely an element in this retrospective study that was modern compared to the GOG trials. Additionally, PET and MRI with contrast were utilized for staging. The patients were recommended to receive weekly cisplatin, 40 milligrams per meter squared, and routine nodal dissection was not performed. And in terms of results, the overall clinical complete response rate was 76%, and the pathologic complete response rate for patients that were receiving preoperative radiotherapy was 58%. And so these were kind of higher response rates overall compared to GOG 205. And in terms of toxicity, there was 29% rates of grade 3 plus acute toxicity and only 6% grade 3 or worse late toxicities. The late toxicities were vaginal stricture and persistent perineal pain. And so it's retrospective data, but dose-escalated intensity modulated radiotherapy seems to be well tolerated with favorable clinical and pathologic complete response rates compared to the GOG studies. Most recently, the GOG 279 trial was published, and this was a phase 2 trial of dose-escalated intensity-modulated radiotherapy with concurrent gemcitabine and cisplatin, so dual-agent chemotherapy. They treated patients with unresectable vulvar cancers, or not amenable to upfront resection, with IMRT 64 gray and 32 fractions to the primary and 50 gray to the inguinal nodes. And they received concurrent weekly dual agent chemotherapy, so 40 milligrams per meter squared cisplatin and 50 milligram per meter squared gemcitabine given weekly with the IMRT. They did report very good response rates, so 73% pathologic complete response rate, 72% clinical response rate, and progression-free survival was 74%, and 2-year overall survival was 70%. So very, very high response rates. I think the concerning aspect of this, however, was the rates of toxicity. They reported 25 out of 49 patients experienced grade 3 toxicity, and 18 out of 49 patients experienced grade 4 toxicity. There was also 1 grade 5 toxicity, likely unrelated to the treatment, However, especially that rate of grade 4 toxicity, I think is a little bit concerning. And in practice, I think folks might be a little bit hesitant to treat with dual agent chemotherapy just because of the additional toxicity of that concurrent weekly gemcitabine in addition to the cisplatin. So the conclusion from GOG 279 was that dose escalated IMRT with gemcitabine and cisplatin seems to improve local control. And it's certainly a regimen to be aware of. I don't know yet that it is kind of broadly accepted in practice just because of that additional toxicity related to the gemcitabine. So with that whirlwind overview of vulvar cancer, we have finally made it to our final slide on major takeaways for vulvar cancer. So I'd just like to kind of summarize everything that we've talked about for both early stage as well as locally advanced disease. So early stage disease should be treated with upfront surgery whenever possible, as long as the patient is a surgical candidate. Sentinel lymph node biopsy is indicated for any disease with greater than 1 millimeter depth of invasion, so stage 1B or greater disease. And if the sentinel lymph node biopsy is negative, then we can omit further treatment. And if there are micrometastases on sentinel lymph node biopsy, then we can utilize adjuvant radiotherapy alone. If, however, there are macrometastases on sentinel lymph node biopsy, currently the standard of care is lymphadenectomy, but the Groin's V3 trial is investigating adjuvant chemoradiotherapy in lieu of lymph node dissection. In terms of indications for adjuvant radiotherapy, so adjuvant radiotherapy to the vulva should be offered for close or positive margins. And remember, less than 8 millimeters was kind of the standard definition for a close margin based on the UCLA data. But then there's that additional Dutch data that suggests that maybe even a 3 millimeter margin is adequate. In terms of adjuvant radiotherapy to the pelvis and the inguinal lymph nodes, if there are 2 or more positive lymph nodes, fixed or ulcerated lymph nodes, or extracapsular extension, that is when we should be thinking about adjuvant radiotherapy to the nodal regions. In terms of adjuvant chemotherapy, there's no prospective data, but this may be of benefit in the case of pathologic node-positive disease. So that kind of summarizes our management for early stage disease. Now, in terms of disease that is locally advanced and not amenable to upfront resection, the standard of care is either preoperative or definitive chemotherapy. And, our practice at UPMC has been to treat to slightly higher doses if we know that it's going to be for definitive purposes rather than preoperative purposes. And we really consider dose-escalated, intensity-modulated radiotherapy. Also, I think importantly to note is that at our institution, patients that have upfront unresectable vulvar cancer typically do not receive lymph node dissection just because of the high rates of morbidity from the procedure and the fact that this can lead to delays in the initiation of chemoradiotherapy. With IMRT to the groin, and especially when the entire inguinofemoral region is completely adequately contoured, from our institution, we have published data showing low rates of groin recurrence with that approach. And so we don't routinely do upfront lymph node dissection in the case of locally advanced disease. So I know that this was a ton of information, and I know that vulvar cancer was a disease site that I was fairly intimidated by when I first started learning about it. But hopefully in this talk, we've been able to kind of simplify some of the major takeaways about vulvar cancer and kind of present the data in a logical way and kind of systematically talk about indications for postoperative radiotherapy for early stage disease that is amenable to surgery, and then also the data for managing vulvar cancer in settings where it's not amenable to surgery, and kind of make sense of those trials. So I hope this was helpful to you, and thank you so much for your time and your attention.